Great. We've got over 30 participants. Let me get started because I appreciate it's a busy day for you. Thank you. Thank you for your participation in the effort trial. Thank you for being here today. Gosh, a few years ago when we had this idea that we could collaborate with this global cooperative to pull off this trial, never, imagined that we'd be here today where we've already got over 900 patients enrolled. Unfortunately, as you know, COVID has caused a challenge for us in enrolling more patients, and we'll talk some more about that. But just so happy to realize that we have a functioning trial, we have great collaborators, we have sites around the world that are engaged in this effort. So this gives us a chance to connect and just give a sort of an update as to where we're at. And many of you have received benchmark reports. And so we feel like maybe you're used to getting them if you participated in the International Nutrition Survey in years past. But for those of you who are looking at this multi-page report for the first time, felt it would be worth just going through that in some detail and seeing if you have questions. And so we'll go through that in sequence then. So let me spend a few minutes just giving you some updates as to where we're at. To date, we have 87 ICUs participating around the world. You can see by the blue line that, again, with COVID over the last year, we haven't really been able to recruit more. We had hope for more, but I think we've tapped out and got, most people who are able to participate under these circumstances are involved in the trial. One of the barriers to getting involved has been the requirement to get informed consent. And you can see from the slide that some sites in different geographic regions have been required to do that, whereas others have been granted a waiver of informed consent, or they have some other third party representative that is able to offer that in Europe. One of the things that has occurred because of COVID is more and more ICUs, more and more ethics boards are looking as to how they can continue, the research process without access face-to-face to a family caregiver who are forbidden from coming into hospitals or coming into ICUs. And so it has significantly altered the ability to either get a waiver or some technological solutions so that either electronically or by telephone, people can now get consent from a surrogate. And so and we've heard anecdotally that this has happened to many, effort sites. And so I wanted to flag that, highlight that, and encourage you that if you're still operating under an informed consent paradigm and COVID is causing that to be, a challenge, that you appeal to your ethics board. And because it's now impractical for this low risk trial to get informed consent, maybe they could change their prior ruling and allow you to have a waived consent. Again, I'm going to pause at the end when we take off the microphones and we can have more discussion and more questions about that. But let me get to a certain point and then we'll stop. And so I'm showing you randomizations, over 900 so far. That's awesome. You can see back before COVID, we hit as almost, I think, in the 60s patients per month. And now and through the middle of COVID, we dribbled down to next to zero. And now we're up to about 23 patients per month. And hopefully over the next year, we'll see some increase in the monthly enrollment. And this slide just tries to project that by year's end, we could be anywhere from 1,000 to 1,800, which, by the way, is still the largest randomized controlled trial of different doses of protein. So even if we had to shut our down operations today, we'd still have a very large data set that will contribute to answering an important question. I've done some back of the envelope power calculations, and I feel like if we can at least get to 1,200, we'd have a shot at having enough power for a time to discharge alive endpoint. Our primary endpoint is mortality. We needed 4,000 patients to satisfactorily evaluate a 60-day mortality. But if we shift to a time to discharge alive, we still have enough power um, at least 1,200. So hopefully by year's end, we have more than 1,200, and we can either wrap up then if it's dribbling down, or we can keep going depending on what the next year brings. Um, so we have lost a lot of patients due to exclusion criteria number 4, where people feel that there's a requirement, either they want to give high protein, or oh no, we have to give low protein, so they don't have equipoise, so they're not willing to randomize. And you can see these reasons here, and we've talked about this before, that people have concern about hepatic or renal function, and therefore they're not going to give them a high dose, and they want them out of the trial. And I keep arguing that, in fact, you don't know what the right dose is, even in these subpopulations. And so there's not really many exceptions where there's really no exception where you have RCT level of evidence to inform you as to what the right dose is. And so we encourage you to work with your clinicians to help them understand that, and to include these patients in the trial. And I think we've talked about this before, and you can see with this slide that over the last couple of years that there's been a decrease in the number of patients who are excluded because of the lack of equipoise, which is good, and we hope that that continues. So that's the essence of the study update that I wanted to give you. I want to spend about 10 slides going through the benchmark report just to highlight what it's showing us. And then I'll pause, and we'll have some questions and answers and some discussion before we wrap up. So what is the benchmark report telling you? Well, we had 46 sites that had that threshold of 10 patients where their data were cleaned and the charts were closed. And we like to group them by geographic region. So you're comparing apples to apples when we do some of this benchmarking. So this just tells you, where the sites came from, what geographic regions. And so here's a very familiar pattern that you'll see over and over again in your benchmark report. And this specifically is the most important slide because it talks about protein intake by group. So the top line here is the number of patients. We always show you your patient data relative to the sister sites. So that's the other countries, other sites in the same country or geographic region, and then by dose. So the usual dose versus the high dose. So you see patients on the first line and number of sites in the next line. Many of your benchmark reports will have low numbers in the sister sites, but you still can compare it to all sites and get a sense of where you're doing. So if you go down here, we're looking at average protein intake received and expressed as grams per kilogram per day. And you can see the usual dose, high dose, and the difference. So this is when each of you look at your site report, you're looking at your data right here. These are the comparator data in the sister sites, and this is the overall with an expression of the central tendency, the interquartile ranges, and the total whisker plot, the total extremes of the data. So what is the inference to be made here? Well, the most important thing that I look at is at the overall, how are we doing in terms of creating a separation between the two groups? We're prescribing 2.2 and 1.2, so arguably we're aiming for a 1 gram per kilogram per day difference. But we know that people don't get the 2.2 or the 1.2, so they get less than that. But as long as that difference is still substantive, we think we can show a difference in outcome. What isn't a substantive difference, or what's enough difference? I'm not sure, but the greater the difference, the better. We're at 0.4, 0.5 grams per kilogram per day, or in other words, we're comparing a dose received of an average of 1.4 to an average of 0.8. I guess that's closer to 0.6 as a difference. So, let's be honest. It'd be great if it were more, but these are the realities of working in your ICUs, and I appreciate that. I think if you're looking at your own site report and you're seeing a difference that is greater than that, that's awesome. But if you're seeing a difference that is less than the average, that would suggest that you're below average in terms of your ability to achieve those targets in the usual care and in the high group. And so I'd encourage you to do what you can to increase that protein intake in the intervention group. You see a table like this in your site report where we're showing you in raw terms, the amount of grams that they got from all sources, from enteral, from protein supplements, and then from PN sources. This is parenteral nutrition and intravenous amino acids only. And so again, compared to your peers, it gives you a sense of where's all your success coming from? Is it just with the enteral nutrition, or how much protein supplements are you giving? How much parenteral strategies are you using? And if you're low, if you're not achieving those benchmarks, or if you're below average in terms of your protein delivery in the high group and the difference that you're creating, I'd have you really examine, number one, your use of um, the, the enteral nutrition protein the solution you're using, whether there's a higher protein content solution that you can access for these patients. I'd have you really examine your use of protein supplements, whether you've bought into the idea of
I find it interesting that
routinely
Kingston is not.
prescribing them. So then to look at the protein supplement issue and see if there's more to be done there. I know that very little people are using parenteral sources of protein or amino acids rather. Um, and then, what more can I say than we think it's safe. We're using it in other uh, projects. But if it's not your practice pattern or you have difficulty accessing the stuff, um, what can I say? Yeah, I'd prefer you use the enteral sources, but the parenteral sources are obviously an option. So just to give you I'm not going to go through these in detail. I just want to, because I think we talked about the most important slide, but I just want to orient you, for those of you who are looking at these reports for the first time, to this kind of way of formatting the results. Again, we've broken it down into usual and high dose. And again, you see the number of patients at your site, the sister sites, and all sites. These are always in the white bars, your data, the sister data in green, and the hatch bars are all sites. And again, usual dose versus high dose. And now we're talking about adequacy as expressed as the amount of received over that which is prescribed. When you're looking at your white bars, these red bars reflect the variation of your patients. When you're looking at these hatch bars, these red plots reflect the variation of the site averages. So the top performing site is up here, the bottom performing site is up down here. So a lot of variation. Again, if you're in the bottom here, I'd ask you to pull up your socks, let us know how we can help. Happy to engage. I'll make reference later on to a webinar that we've already recorded that looks at different strategies to improve nutrition delivery. So that was, I think, protein. Now we're talking about calories. And we also get into from enteral sources, since that's your predominant strategy, just to see how successful you are from the enteral route delivering protein, or from the calories from the enteral route as well. So the other slide that I'll just spend a minute on is just this ranking slide. We used to do the best of the best, and so we ranked sites by their performance on these different metrics. And so again, you can see your performance. This is with respect to all protein compared to your sister sites. You're third out of four compared to all the sites. You can see, if you slide that white line along, you're about here, so you're above average. You rank, about 14th out of the 46 sites. So someone out there is looking at themselves as number one out of 46, and kudos to you. We want to reach out to you and see what you're doing differently to achieve that success, and perhaps share your secrets with the rest of the cohort. But good for you. So, but again, if you're looking at yourself and you're seeing that you're down really low, we're going to have a conversation, because you may be jeopardizing the quality of the trial if you're really delivering substandard nutrition in both of your groups. So just a few other metrics, and then I'm going to pause and we'll see if you have questions or comments. Um, timing to initiating feeds is an important issue for the trial. We want you to follow best practice and get started within 24 to 48 hours, and you can see that that's happening on the average. We've had some delays, and some of the data points show extreme delays, and we know that some mistakes have occurred, and we're trying to work with that. But on average, we're doing pretty good in terms of getting the nutrition, enteral nutrition up and running early. So that's good. This is another opportunity for improvement, perhaps, where we're still predominantly feeding gastrically. And I imagine that's partly why we have low intake, is the intolerance or frequent interruptions. And so encourage you to think about concomitant motility agent administration and or small bowel placement as a strategy for optimizing nutrition delivery. So again, those are opportunities for improvement. One of our concerns would be if we're giving too much, particularly in the high group. I believe these data points come from all the patients, and so it's not a reflection just of the high group, but overall. And so you get a sense of metabolic tolerance, or said differently, intolerance, and very low percentage points of people with days with a high blood sugar, or more importantly, days with a high blood sugar with truckloads of insulin, and using lots of insulin, or having high triglycerides, or having a high urea. So I'm not too concerned looking at this at a global level. If you have concerns about it looking at a site level, let me know. We can talk about it, and there's some suggestions there. So I'm going to pause here for a minute and just see if you have any questions on anything I've said, which is about our progress, the impact of COVID, the concepts around consent, about the benchmark reports, how we're interpreting them, and then obviously what can we do differently to increase protein intake in the enrolled group. That's the nature of the conversation I'd like to have. So I think you can take yourself off mute if you have a question, or if you want to put something in the chat room, I'm happy to respond there too. Please.
Can you hear me?
Yep.
Hi, this is Mary. I have a question from Phoenix about the protein supplementation. So if we are using IV amino acid, or if we're supplementing with, would you suggest that we just use the IV amino acid? Because that hasn't really been a practice pattern. Or are we referring to like supplemental TPN with dextrose, or is that just patient dependent?
Yeah, the latter, patient dependent. I mean, I think either is an option, and it depends on if you need those calories or not. And so it's your judgment as to whether, if this is a nutritionally high risk patient in their early course and they're really not getting much of anything, maybe the PN, supplemental PN, would be a strategy. Having said that, if there's someone there that's getting 60% of their calories and maybe some propofol, and you don't really want to give them any more calories, then you would just give the amino acids if that's available to you.
Okay, thank you.
I have a question about figure 1. Is your example, in your example, your site, is the example good or bad? The difference. That was actually a good, let me just pull it up again. I believe this is the figure 1 that you're referring to. So in your site, someone's at 0.85 as a mean difference. That's great. That was one question. Sorry, I've lost my chat room. Is there an opportunity to extend the study end date? So what is the study end date? That's a good question. Right now we're projecting to the end of the year, but I mean, really, it depends a little bit on COVID and what happens here, right? Because if we have a lot of sites who have pulled out of effort, and if that continues to happen because of reprioritization of resources and time, I can't keep the method center open forever when we're only getting 10 patients per month or 5 patients per month, because that we'll never get to 4,000. So what I'd like to say is it's February right now, so let's keep going and doing as much as we can, and we'll reevaluate in the fall based on our enrollment rate, based on COVID, and based on our resources to keep the method center open. So that's the best I can answer that question right now. Other questions? If you don't have a question, I really love feedback on as to the barriers at your site. I mean, if there's reasons why you're not able to enroll, if there's reasons that we haven't talked about, or if there's reasons why you can't get the protein intake up, I just like to hear some feedback about the challenges that you're having, just in case we can brainstorm and help solve those.
Dr. Helen, have another question.
Yeah. You mean the chat one?
Yes.
Yeah, okay, yeah. Our site is planning to get started with the study. Our site was approved, but enrollment was held for COVID. Yeah, I appreciate that. That's happened in many places. And again, so a lot of institutions make those decisions that no elective non-COVID research will continue. But so we obviously don't have any say over that. But when that institution again grants you the rights to do that, go for it. Think about exploring these things about lack of need for informed consent, or at least some alteration to the consent process if that's required during COVID, if that will help you get enabled. Another comment here, I use Peptamen Intense to ensure meeting protein targets because our RNs don't either give it or our pharmacy won't include it in the MAR, or they don't document it. So you're talking about protein supplements. Yeah. So again, high dose protein containing enteral nutrition solutions is perfect, is ideal. We'd love you to use that. You may even need on top of that a few protein supplements, but I appreciate what Linda is saying there, that oftentimes it's hard to find documentation that it was given, or the nurses forget to give it. Some sites, will leave a piece of paper behind so that, and ask the nurse to record it here because it doesn't get into the MAR or doesn't get into the electronic record. But if you're coming by daily and you have them fill out a form that you've created that you can use as a source document, that works from our side as well. You just need some documentation that it was given before you can put it into the red cap as something given. But we recognize this problem for sure. Other questions or comments? Anybody struggling with the interpretation of their benchmark report? Kristen reflecting that my ICU is continuing research during COVID. The main barrier is time. I try to have 1 to 2 patients enrolled at a time, but I'm too busy to do more. How should I complete my screening data accurately to count for my lack of time? Good question. And we've tried to encourage you to think about your screening as an on-off switch, so that when you're on, whether that's in a given day or screening all day, then record the screening data there. But maybe you've got 2 patients enrolled, so you're going to stop. So the switch goes off and you don't record any more screening data. That might happen on a given day, so that for the first hour you're screening, record that. But then you say, oh, I'm overwhelmed and I've got this, and so you stop. So if you're not actively screening on a given day or over a given week, don't necessarily need to send us screening data. Okay, so Mary made another point about the informed consent. We are required to consent patients surrogates, which is a barrier. Yeah. But she asked the IRB to reconsider the waiver and was denied. However, they did approve a virtual DocuSign process, so we can move forward. Just wanted to share that idea with other sites. Uh, Great. Thanks for sharing that, Mary. The other thing that it triggered was in some sites, REDCap itself has an electronic consenting tool. Not the version we're using for this trial, but if a site is also using REDCap centrally for their research, you could partner with your site's administrator of REDCap to try and use that e-consenting process, which IRBs are more likely, are approving these days because of COVID. So I just draw that to your attention. If you're required informed consent and you can't get an alteration, the e-consenting process is an acceptable and is acceptable. Find a partner who's already doing that at your institution and see if you can use that for your consenting process. You're not using their REDCap to collect the data or to do the randomization, just the consenting process. Sasan is sharing in the chat room there that part of the difficulty is people are being extubated so quickly, and so it's hard to find, those long stay patients. Yeah, I think that if we want to show value to protein intake, we need long stay patients, and so I don't want to change your practice. Your physicians are doing a great job, but you'll just have to be a bit more selective to those people who do stay, ventilated for more than 48 hours. Okay, so someone's asking about some documentation that having a high protein formula would be helpful for the trial. Yeah, I can do that. Remember that though in the protocol, I am not specifying what formula should be used, and so I want to be very clear that I'm not amending the protocol to say that thou must use it. But as a general guidance document that, protein's important, we need to get higher amounts of protein in, this is a recommended strategy, I'm happy to do that. And Jen or Alfonso, if you could make a note of that, we can put that into some future study communication. If that helps, you lobby locally for access to these products. Other questions or comments? Let me just see what my last two slides were. Yeah, I think that we've addressed a number of these things. Just some encouragement to share the results of your benchmark reports. If ideally you've got a quality improvement committee in your ICU, and you're discussing with your physicians and nurses and other allied health collaborators that there's either good news or there's okay news or there's bad news, and certainly if you're on the needing improvement end of things, that you're collaborating with them to problem solve and accessing the products or the processes that are necessary for you to do better. And again, I'm more than open to be more than willing to be involved in helping problem solve if you want to engage me. Just another encouragement that if you could keep enrolling, that'd be great. We can keep the study open as long as it looks like we're beating down the COVID wave and trying to keep people going. For those sites that have already enrolled patients, we do kind of put pressure on you to close the charts out, because we can't generate these kinds of reports or even internal reports or touch base reports until you actually have data in the chart. So you'll hear a lot of nagging from us in Kingston to please keep those charts as current as you can. I mean, obviously it's more important that you enroll patients, but it's just as much as you can. Please keep those charts closed. Sorry, there's another question. Will we receive some analysis pertaining to impact on healthcare costs when using scientific formulas in these different protein doses? So in terms of cost being an outcome, we're not actually doing a micro cost accounting approach where I'm tracking, resources in, resources out. But I imagine if it's a positive study, we can do some modeling based on the cost of product and the length of stay or the time to discharge alive, if there's a difference there. So that will be a secondary analysis that emerges from this, but will not use the raw data on the costs, but rather we'll model it. Okay, well, that was all I really wanted to share with you today. I don't see any new questions coming in, and obviously we're certainly open and receptive to further.
Aaron,
Yes, please.
this is Charlene. I have one.
Okay, go ahead, Charlene.
I'm curious to know how successful people are being gathering the malnutrition data for this study, because Darren has told you it will be the largest protein dose study, but it will also be the largest study looking at high nutrition risk patients and the effects of protein. Are those hard, easy, impossible together?
Any feedback from the sites on that? Charlene, I know I can tell you, or I can't tell you right now, but we can dig it up out of the analysis, the frequency of missing data on those various data points. So I can't remember if it's in the site report or not, but certainly not on my slides. But we can share that with you after the fact. But if any sites have any comments on the difficulty of obtaining the malnutrition diagnoses or the nutrition screening risk, that would be helpful.
Okay. Linda says in the chat she has a malnutrition screening protocol in place on admission. So that's good.
Any other questions or comments? Okay, well, I think we'll wrap up then. And again, let me thank you for your participation. It's voluntary, I know that. I hope you get some benefit out of being part of this global collaborative, out of receiving a benchmark report that helps you, identify your performance, and some sense of satisfaction knowing that you're helping our community answer a very clinically important question. So keep it up. And feel free to reach out if you have any further issues or questions regarding your benchmark reports or the trial overall. Thank you very much and enjoy the rest of your day.
Nice presentation, Darren.
Thank you, Charlene. We'll be in touch. Bye-bye.
Bye.